Okay, the PowerPoint's really just to keep me on track, so I make sure we cover a little bit in each chapter. There are some concepts that I think are a little harder to understand, and we'll cover those in more detail. Um, and just hit on a few of the concepts in each chapter that I know that exams hit heavily on, and the things that are covered in um, unit exams are also content that I believe that will come back and get you on HESI as well as NCLEX. We want you to understand the concepts that are important to um, maternity nursing overall, not just that you have to try to memorize or understand for our unit exams, but are important to the overall concept of maternity nursing. So we're going to cover the content from weeks 1, 2, and 3 today. Um, So chapter 1 was really just an introduction just to get you familiar with maternity nursing. There's not a whole lot of content in chapter 1. Chapter 2 talked more about family culture and how it affects our nursing care in-house, and some of the concepts that I think are important to your overall nursing practice are how we approach students or approach as students or nurses or patients as far as their medications go, and um, the culture that they come from. Sometimes they don't take their medications appropriately, or they may use herbal remedies or um, medications that they maybe are not pharmacological meds that we think are appropriate, but that um, are um, things that they have been passed down through their families. And as long as they're not harming them, and they feel like they benefit from them, um, it's good for us to support that. The one thing that I think of that directly affects nursing in maternity care is with nausea and vomiting. A lot of women will use ginger to control that, and that is okay in small amounts. But if they're grating ginger and putting it in ginger tea, ginger can cause preterm labor. So if you have a patient that tells you that they're using those supplements, if it is a ginger tea that's prepared and they're purchasing it at the grocery, there's usually not enough ginger in that to cause a problem. But if they're grating their own ginger and preparing it at home, they can induce labor with overdoing it with that. So it's something that you want to explore if it's a cultural thing and they're preparing it themselves. Good morning, Nunu. Um, Other things that are appropriate to talk about in this chapter are vulnerable family groups, and some family groups are more vulnerable than others. And we think about a the family groups that have the mother and father in the home and the children all living together, and the whole happily ever after, and that's great. But there are, we've got parents that um, are are single parents. We've got parents that are blended families, um, that are coming to us that um, there may be divorce situations that are not good, and we think of those families being at risk. But the most vulnerable are the single parents who have no extended family or have no support system. So they're really even more at risk than those that are um, blended families that we think of as being at risk. So that was one of the takeaways from chapter 2 as well. Um, Let's move on to chapter 3. Good morning, Shelby. Glad you joined us. Assessment and health promotion. This is where we were assessing our either prenatal patients or our clients who were thinking about becoming pregnant, and some of the things that we were looking at that put them maybe at risk. And what were your 3 things that we talked about that puts a client at risk initially? Do you remember those 3 big risk factors?
Like health issues,
Yeah.
diabetes, hypertension.
Uh-huh.
Smoking.
Was it
Smoking
obesity?
does.
Was it
That wasn't one
obesity?
of the big 3, but smoking does.
Was it obesity?
Yep, that's it. That's the 3rd one. Um, Hypertension and obesity put the baby at risk too for being small. It puts them at risk for intrauterine growth restriction, because anything that constricts those blood vessels will make it hard for the baby to grow. They're not getting a good blood supply. They're not getting good oxygen. So it's very likely that those babies are going to be small. So those are good reasons that we're going to have a compromised baby. Oops. She's having trouble getting it. Hello, you're back. So we're looking at moms with those, all of those factors put mom at risk and even the baby at risk. If when we talk about obesity, we're looking at a BMI. What's a normal BMI?
18 to 24.5 or something.
29. I don't remember.
Okay. Anything over 30 is considered obese. Okay, greater than 30 is obese. What if you've got an adolescent, and adolescents are at risk just for their age in general. Young kids are at risk, and elderly elderly moms that are like 40. That sounds bad, doesn't it? But older moms are at risk as well. But when we're looking at weight and age, our young teenage moms are at risk because, number one, they don't eat well. They eat Cheetos and Pepsi for lunch. you know, so they don't have a healthy diet. A lot of times they don't have a support system, and quite often that is what has attributed to them being 15 years old and pregnant. So they don't have a good nutrition system. But when we're talking about our BMI and our weight gain, or setting our babies up for success or for health, um, if we've got a mom, a 15-year-old mom who is just barely under the BMI limit, we're not going to get really bent out of shape if she's just a little bit underweight, just a few pounds, because once she knows she's pregnant, if she starts eating appropriately, gaining that 1 to 4 pounds of weight in the first 13 weeks is certainly appropriate for her. We might do some counseling, talk to her about nutrition, but we're not really going to have to send her to someone to talk about anorexia or eating disorders or anything like that, because lots of teenagers fall into that category, that they are minimally underweight. That's typical of teenagers. Now, if she's 5'2" and 78 pounds, that's not normal. Okay. So if she would be in that category, then we might need to send her to someone for psychological counseling for eating disorders. Does that make sense? There's a big difference between being a few pounds underweight and having a marginal BMI, that once she starts eating healthier because she's pregnant, she's going to be fine. And we're going to be looking more at, is she going to going to gain that 1 to 4 pounds during the first 13 weeks of pregnancy, versus getting bent out of shape, that she's not at that benchmark of her BMI being normal. Does that make sense, that we're using kind of common sense to determine what we're going to do with her, because she's at the low end of her weight range? Am I making sense?
Yes.
It's early. I know. Let's see. Okay, preconception with our health assessment and our health promotion. If we have a patient who's just thinking about getting pregnant, what are we going to talk to her about?
Her diet.
Her diet, vitamins. What's an important thing to prevent, like neural tube defects and all of those?
Oh, folic acid.
Yeah, we want to get them on folic acid because of the anencephaly and the neural tube defects. So we're going to be talking about those things. We've already really talked about the patients who are at high risk, which are hypertension, age-related, those with high or low BMIs. Okay, let's move on. Chapter 6. That's our conception and fetal development chapter. So that's where we talk about recessive and dominant genes. And we were just talking about neural tube defects, but we know that when we have recessive genes, that the infant has to receive both genes that are abnormal in order for it to be exhibited. So important to keep that in mind, that that's part of the genetics piece. And with Down syndrome, when we talked about those babies, we talked about the simian creases and the brush-filled spots. And we looked at our hands, and the lines are separated. And those babies with Down syndrome, a very high percentage of them have the straight line or the simian crease in their hand. And we talked about when we give that first bath, that's one of the things that we look for. And they have the anomaly in their toes. It's I can't remember the medical term for it, but we call it sandal toes, where it looks like they have a pair of sandals on the big toe, and the second toe are kind of separated, is very common with Down syndrome babies. So there are things that we look at visually. One of the things that they see on ultrasound with the Down syndrome babies, excuse me, or the bone in the bridge of the nose shows up on ultrasound very early. The bowel involvement with the Down syndrome babies, and the heart anomalies that go along with it, all part of the fetal development that happens with those babies, are very common. What are some other development things that you talked about in chapter 6?
The other trisomies, 13 and
Yeah.
what was the other one? 18.
Okay.
Is it Edward syndrome? They don't live past like a young age.
Yeah, they expire very early. So you don't have very many babies that are that you're caring for with Edward syndrome. Okay. So chapter 7, anatomy and physiology of pregnancy. We talked about anatomy quite a bit, implantation happening in the endometrium of the uterus, and not in the fallopian tube because that would be an ectopic pregnancy and the tube cannot maintain a pregnancy. Let me see what else we need to know about that from chapter 7. Do you have questions about anatomy itself before we move on more to the processes of labor? Okay. We're going to talk about care of family and the patient during labor. We talked about we started kind of talking about labor this week, and I think that's kind of a more exciting time as we're caring for our patients and their families. We're going to be keeping in mind that we have a room full of clients. Okay, so if you have a patient whose say 6-year-old daughter is going to be in the room with them for delivery, and mom is getting uncomfortable, and the child, you can tell, is getting scared, how would you handle managing that child? What would be some interventions that you might do with that child? Because we're
Calming
caring
techniques.
calming techniques. Yeah.
Maybe ask the family to go grab something to eat or drink and let her have a minute.
Sometimes a break is good for them.
Distraction, like get something age appropriate to keep them busy and away from what's going on, but in the same room.
That's perfect. Age appropriate is the exact thing that I was looking for. When you're answering questions, whether it's on an exam or on HESI or whatever, look for something that talks about being age appropriate. So we're interacting with that child on their age appropriate level. So explaining to them what's going on something that's on their level. And sometimes I think that that's hard for parents and grandparents in the room to do because they're processing what's happening in the room at an emotional level. And it's hard for them to appropriately interact with that child. So it's important for the nurse to bring it down to that child's level so we can help them process what's going on, because it is very emotional, especially up until the point of an epidural, or if the patient does not get an epidural. There's a lot going on in those rooms, and it's really hard on those young children. I definitely good with them being in there and experiencing with their parents at 6, 8 years old, but I think we have to help them understand what's going on because parents and grandparents aren't always able to do that. They're not always prepared because they're at a very heightened emotional state when they're in there as well. At this point, as we're caring for parents, a lot of times moms will have leg cramps, and what can we do to help them with their leg cramps? We'll talk about, I'm not even sure what chapter, maybe the next chapter is talking about comfort measures, but when we're talking about comfort, what do we do with the leg cramps that they're having?
Massage.
You can, but you have to be careful because if there's any risk of clotting, But you can massage gently.
Passive range of
Range of motion is good. Moving them around. What do
The
you do for
medicine ball.
like med surge? I didn't hear you. I'm sorry, Shelby.
Maybe use the medicine ball to prop them up or put them on their side and put it in between.
Yeah, moving around like you were saying, and using the ball to reposition. That's good. What do you do in med surge when someone has leg cramps?
SEDs.
SEDs.
Yeah. Um, if you pull their toes up towards their nose, do the dorsiflexion, that will stretch out that muscle, and it helps tremendously. That helps in med surge, and it helps in maternity too. It helps stretch that calf muscle out and reduces the leg cramps. What are some other things that we do? What are some symptoms that you would report immediately?
Trouble breathing.
Trouble breathing.
DSATs.
Okay. What if their water broke?
That too.
Yeah, that's you. You'd report if they had vaginal bleeding, right? Spotting, not as much of a big deal. Moms sometimes have spotting after intercourse or after a vaginal exam. So a little spotting, a little dark blood after that is okay, but you would report if they had bleeding. If there's a seizure, if they have severe headaches, anything that's indicative of preeclampsia, we're going to report. I think our next slide talks about nutrition. Let's talk about some nutrition. We talked about weight gain, or being 1 to 4 pounds in that first 13 weeks. We know moms gain more weight after that, but we want them to be eating an appropriate diet. What kind of foods are appropriate for the pregnant mom? What's an appropriate diet?
diet that's I guess like a heart healthy diet, my plate diet type diet.
Yeah, that's good. Yeah. We want it to be complex carbohydrates, don't we? We don't want it to be simple sugars. That's not good for anyone. But we also don't want it to be like all salads and greens. That in a med surge class, the green leafy vegetables is almost always the right answer. Not here. Green leafy vegetables doesn't have much nutrition in it. So we do want them to have more nutrition. So complex carbohydrates are good, and they need more vegetables that have more nutrition in them than just those green leafy vegetables that are kind of like rabbit food that are a little healthier for our hearts, maybe. So a little more in their diet. Some protein. These babies need protein to grow. So a broader spectrum, like you were saying, the healthy plate diets are good. And we want to be sure that we're encouraging them to keep taking their vitamins and to keep taking their folic acid, because that's, again, good. We want them to maintain their weight. Sometimes people who are starting out obese will lose a great deal of weight during pregnancy because they're eating healthier, and they're going to be monitoring the baby to make sure the baby's growing well. And it's okay if mom is obese to begin with, if she loses weight, as long as she's eating a healthy diet and the baby's growing appropriately. Sometimes if she's eating healthy, her weight may drop, but the baby will still be growing. So that's something that I think people will get worried about sometimes, if during pregnancy that their weight goes down a little bit. But if they're eating healthy diets, that does sometimes happen. Sorry. Um, high risk pregnancies. What makes mom a high risk pregnancy? We talked about some factors that would make her high risk going into her pregnancy, but once she's pregnant, what would be some things that would make her high risk after pregnancy?
Her age.
Yeah, that's something that sets her up initially. Yeah.
Mm,
The age, the hypertension, and the diabetes.
preeclampsia that could develop.
Yes,
Smoking,
preeclampsia,
smoking.
smoking, yes. Preterm labor makes her high risk that develops during labor. So that makes her a high risk patient at that point. What else?
If the baby has something going on, like Down syndrome, possibly.
Yes. That definitely does, because a lot of times moms will abort if they have a baby that has a genetic anomaly. And a baby with any kind of growth restriction sets her up for a high risk pregnancy, because those babies sometimes do not thrive and do not survive. So that sets her up for a high risk pregnancy. Okay. Okay. Labor and birth processes. We talked this week about the 5 Ps, and that's something that you'll probably need to know again. The passageway, the passenger, powers, the psychological responses, and the position. I think the one that's kind of hard to remember is the powers. That's the pushing and the contractions. So mom's involved and her body is involved.
What was after powers?
Powers, psychological responses, and position.
Is this?
That comes, I think, from chapter 13. So it's the 5 Ps. And really that's really just memorization. Quite often, the types of questions I've seen, whether it's been on, I haven't seen HESI, but on ATI questions or NCLEX style questions, will give you like a select all that apply and ask you which ones are not appropriate or which ones are the 5 Ps, and they will make up some extra ones and see if you know which ones the real 5 Ps are. So your passageway is the mom's pelvis. Your passenger is obviously the baby. The powers are your contractions and your mom's pushing. And the psychological response is how mom reacts to it. And the position is the position of the mother. Okay, so that's your 5 Ps. Okay, one thing that we have not talked about yet is the GP DAL. And that comes up a lot whether it's, I know it was on your quiz, it comes up on testing, as a method of tracking your patient's pregnancy history. Do you all have questions about that? I can pull up a slide if you do. We can go over it.
Did you pull up the slide?
Sure. May just take me a moment to find it. Do you remember what week we went over that? Is it week 2?
Yes.
Okay. There it is. Oh. Okay. The G stands for the total number of pregnancies, regardless of whether it's a single baby or can be twins or triplets, doesn't matter. So you're going to put down how many pregnancies they've had, and it includes the current pregnancy. So if this is pregnancy number 3, and she's got 1 baby at home. Let's just start making a tally here. She's got 1 baby at home, and this is pregnancy number 3. So she's a gravid of 3, and 1 baby at home. So she's got 1 living. So she's an L1, gravid of 3. She had that 1 baby she had at 38 weeks. So that means she had a term baby. So that's a T1. She's had no preterm deliveries. Okay. So P0, but she lost a baby at 8 weeks. So she is 1 abortion. So that makes her a G3, P1 or T1, P0, A1, L1. Does that make sense?
Yeah.
Okay. You give me a scenario and we'll talk through it then.
So for the quiz yesterday, the answers weren't written out like that.
Not at all.
The
How were they
answers
written?
were just G, a number, and then 4 numbers.
It was
There
very
wasn't
confusing.
it was confusing because there wasn't a G, T, P, A, or L. And between the numbers.
And then the
Yeah.
question was very mixed up, like talking about twins and then a living daughter, then one twin died.
Yeah. Do you guys know what the answer was? Was the G 5 or 4?
It was 4
I don't even know.
pregnancies. It was 4 pregnancies and 3 live births.
So G was not 5.
No, because you don't count twins as 2 pregnancies. It's only 1 pregnancy.
Oh.
So the living children at the end, you would count the twin. Well, you wouldn't count both twins because one of them died. But
You don't. Okay. So twins is 1 pregnancy.
Yeah,
Gotcha.
twins is 1 pregnancy. And yeah, you don't really put the letters in here. So in your mind, in your notes where you're writing them down, I do because it's confusing for me. I put my little letters there and I talk my way through it. And then when I put it on the chart, you don't, you just put the numbers or dashes between them. Honestly, in labor and delivery, we don't use this. Now, in the doctor's offices, it's on their charts, but we do gravida and para, and then everything's separated out. So it will say living children or spontaneous abortions or terminations. There's places for you to write it in. So
Yeah, I wrote it down yesterday because I was so confused, and this is literally one of the answers it gave us.
that is the answer.
I don't know. It's one of the ones I wrote down because I was struggling, but that's what
Okay.
it looked like. Like that makes no
Okay.
sense to me.
Okay, that's the G4 P2 and then 10
103. Like
G4 P2 103. So that would be she's gravida 4, para 2, means 2 term deliveries.
so para means term deliveries.
No, not really.
I thought the P was preterm.
Yeah. Can we get somebody to
Yeah.
like re-look that question? Because even like my classmates in different classes was all having the same problem with that same exact question.
Yeah. Yeah, we'll look it up. After class, I will go pull it and see if I can tell.
So what is the parity? Like, is that the TPAL?
Mm-hmm.
And
Yeah.
okay.
I'm going to look it up in your book just to tell you exactly what the actual definition is for it. So there's no confusion. What chapter was this in? Was this week? This was week 2. Because on here, P is preterm deliveries, but that's not what parity is on what you're looking at. It's number of deliveries.
So when I'm going through those, I write down G T P A L. And then as I read through the question, I do like this. And then as I read through the question, I put like a check mark by it to tally it up.
Yeah, I put a number by it. That's the way I do it too. Yeah.
Yeah, just that question really threw me off with how the answers were set up.
Yeah. It's the number of pregnancies that have reached 20 weeks gestation. regardless of outcome, is parity. So in the GTPAL system, I see where you're getting confused in that question versus I'm not sure how the question was set up in your quiz. I tell you what, as long as are you guys okay with me going back and pulling the quiz while we're talking?
Yeah, that question.
Okay. I don't want to waste your time, but I mean, if it comes back on the test, I want you to know.
I probably spent a full minute just trying to understand it with how the answers were set up because it was not making sense with GTPAL, like the order we're learning it.
Yeah. Okay. Let me go back and pull, because I have no part in making the questions on the quiz, so I don't always know how they're stated or really what's on there for sure. Okay.
So for the abortions, that's counted as if like they were 5 years old and passed away?
No, that's in utero.
Only in utero?
Mm-hmm. That's if you've lost a baby through what we consider miscarriage or a termination, either one. A fetal loss below 20 weeks.
Below 20 weeks?
Mm-hmm. Yeah. Or I guess if you had a termination above 20 weeks, a termination would be an abortion. So, but a missed abortion is, below 20 weeks. Okay, here's a question. A woman with an obstetric history indicates she is currently pregnant. Let's start a tally here. So she's currently pregnant. That's one pregnancy. Her OB history includes a daughter born at 32 weeks, twins at 37 weeks, 2 babies. Let me let somebody in there. Okay. A daughter born at 39 weeks. And one of her twins passed away due to birth complications. Okay, so one of the twins died. What is her gravida and para using the GTPAL? system. Okay, so she is 1, 2, 3, 4. She's G4. How many term babies did she have?
Can you repeat it?
Yes. A woman's obstetric history indicates that she is currently pregnant. Her OB history includes a daughter born at 32 weeks, twins born at 37 weeks, a daughter born at 39 weeks, and one of her twins passed away at birth due to complications. What is her gravity and parity using the GTPAL system? So she is gravida 4.
So born at 37 weeks would be preterm or term?
37 weeks would be term.
Okay.
So she is gravida 4.
So she had 2 term,
Mm-hmm.
1 preterm,
Right.
0 abortions.
She would have 1 abortion, right?
0 abortions.
0.
Abortions
those-
20 weeks or less, right?
Right. And she has 1, 2, 3 living babies. So 4203. Is that what you guys got?
42103.
Oh, 42103. Yeah. Yeah. 42103.
I don't even remember what I put, so I couldn't tell you.
Yeah. And it does get confusing, and I just think that I have to write it all. I have to write it down. It's like a math equation for me. I have to write it down and go through it. It's not something I can just think about and look at the answers, because I have to write them down, or I'll miss it every time. Okay.
So what was the answer on the quiz for that one then?
It would have been what we just.
Because how it's said is G4P2, not GTP.
That would have been the answer. G2 P10, because that's the way the answers were written.
I thought they were written G4P2, not GTP. Or is there one on there that does have a T?
You're right. They are written G.
They're written very odd, and yeah.
Yeah, they're written GP, G4P.
With random 3 numbers after that.
Yeah. I'll check on that, because it's written odd. Yeah, I'll check on it and see why it's written that way. And if we can, we will give credit back. You know, if they think it's confusing, then because she had what, 2-term babies, right? Okay, well, let's talk about a couple more things and I'll go back and look at that for you. For sure. I can't get you back. Okay. A couple other things I wanted to talk about before I let you go is delusional anemia is something that I know last term a lot of students struggled with. And as when we talk about pregnancy, our plasma volume increases during pregnancy. That's one of the first things that happens is our blood volume increases. And when that happens, it looks like we're anemic. It goes by a couple different terms: physiological anemia, or dilutional anemia. And it's because the plasma volume increases before the red blood cell count does. So as the plasma volume increases, it looks like you're anemic. But then the red blood cells will kick in because our bodies need to take more oxygen to the baby. So the next thing that happens is your red blood cells start to pick up and we produce more red blood cells. And when that happens, the anemia seems to disappear because you have more red blood cells floating around to carry more oxygen to the baby. It's called delusional anemia, or that's what it used to be termed as, because the plasma dilutes the red blood cells. So those are things that happen. Normally, that's a normal lab change, lab value change that you see with pregnancy. Things that should not change are things like white blood cell counts. What do white blood cells do?
Fight off infection.
Yeah. Should you have infection when you're pregnant?
No.
No, not really. I mean, unless you would have a UTI. UTIs are kind of common, but that's not something we want you to have. That's not a normal physiological change during pregnancy. But increase in plasma volume is, you know, our plasma picks up during pregnancy. So that's a normal change. And then eventually the red blood cells are going to pick up because we need to carry more oxygen to the baby. Our red blood cells carry oxygen. So that's a normal physiological change that we're going to see on our lab values. So those are things that we should see change: plasma volume and red blood cell count. Another thing that people had trouble with were decelerations. What are early decelerations a visible sign of? What do they indicate?
Baby struggling.
No, I mean, yes, and something's happening to the baby, but what's it an indicator of?
Is it cord compression or is it head compression?
It's head compression. Yeah. Early decelerations are the good ones because as the baby moves down into the pelvis, the head gets squeezed. So early decelerations are good and they mirror the contraction. Okay. So early is good. It starts early in the contraction, and when the contraction's over, it comes right back up. Okay. So early is good. Late decelerations. What are late decelerations indicators of?
The baby's in distress.
Yeah. Late is bad. The baby has gone through the contraction and it's nearing the end, it's late in the contraction, and it's given it everything it's got, and at that point it can't hang on any longer, and it's going, help, get me out. Okay, the contraction's almost over, the baby has struggled, it's got nothing left, and it's saying, help me. That's when the heart rate drops down, it can't hang on any longer, and it's just done. So late decelerations are the ones that we are concerned about. Late decelerations indicate uteroplacental insufficiency. It just can't hang on any longer. So those are the ones that we worry about. Those are the ones that we're going to have to intervene and do something. So early ones that mirror the contraction just mean the baby's being squeezed. It's time to get the baby out. You know, that it's coming through the pelvis. It's time for delivery. Get things ready. Get your delivery done. Everything's okay. Late decelerations is the baby saying, help me, get me out of here. Variable decelerations are usually cord compression. They can be, we call them variable because it can be a lot of different things. Okay, can be varied reasons cause variable decelerations. Sometimes we just flip the mom over and it goes away. It can be wonky things like the baby's holding onto the cord and squeezing it or chewing on it, or it can be any kind of wonky stuff that causes variable decelerations. To fix variables, we sometimes we turn them, we put oxygen on, we increase the IV rates, we do things to intervene, and sometimes they fix it, sometimes they don't. But variables are not as serious. Variables look really weird on the monitor. They have a sudden drastic change. They drop suddenly, but they come back just as suddenly. So they are odd in onset and odd in recovery. They often have a little shoulder when they recover. Like when the baby's heart rate comes back to baseline, it'll have a little bump and it'll have a little acceleration before it comes back to the baseline. So they look odd on the monitor, but you can always remember early decelerations are head compression and they're okay. Baby's probably going to deliver soon. We don't like any kind of deceleration. We would prefer not to have them, but early are your best because the baby's getting delivered. Variables are really not something that we're all that concerned about. And late decelerations are the ones that we're probably going to have to intervene. We're going to watch them closely because that means the baby is in distress. It's not compensating because it's uteroplacental insufficiency.
So if we see something about this, will it be set up like that veal chop, or just ask us like about the different decelerations?
It will probably be asked like a scenario kind of thing where you'll have to figure out what you're going to do about it, you know, based on what kind of deceleration it is. The veal chop is just a way to help you remember whether it's important or not. Let's see if I can give you an example. Like a prolonged deceleration is that doesn't even really tell you what kind of deceleration it is. On one of my slides when I was teaching a prolonged deceleration, you're going to call the doctor because that means the baby's not recovering. Okay, so we're more concerned about what that baby's doing with that deceleration or what that deceleration means. Like the veal chop is just a way of remembering the differences in the decelerations. I always want you to like make it make sense and not try to memorize things. Okay, so like for example, if you have head compression, you see those early decelerations and you know it's head compression, the baby's coming down and the contraction's there and the deceleration is mirroring that contraction. So you know that little head is being squeezed. You're almost, they're complete. They've been pushing for an hour. You know that baby's coming out. So what are you going to do when you see those head compression decelerations? You're going to turn up the IV. You're going to turn her over on her side. You're going to put on oxygen. None of those things are really going to hurt her, but are they going to fix the problem? What's going to fix the problem? Getting the baby out.
Yeah.
Yeah, getting the baby out. So when we know that she's pushing, we're getting close to delivery. What's our priority? Our priority is getting the baby out. So we need to get the nursery nurse in there. We need to get the table of delivery instruments in there. We need to get the doctor in there. So prepping for delivery is your priority. Not that you might not put oxygen on or do the IV. So some of those things you might be doing simultaneously, but our priority is delivering that baby, because head compression means that she is about to deliver. Okay, so our priority at that point is delivering the baby. Now, with late decelerations, she's not about to deliver, so we need to do something to fix that. If you have a late deceleration, you're going to try to fix it. You're going to put oxygen on. You're going to maybe turn her over. Variables, that's the ones we're flipping them around, because it's probably cord compression somewhere. So we're going to flip them. We're going to put oxygen on. We're going to turn up the IV. We're going to do all of those things that we can intervene, to get the compression off that cord. Those are going to be our priority things with variable decelerations. Late decelerations, we're going to try all that stuff too. If we have a late deceleration, we're going to try to intervene. If we have more than one late deceleration, we're going to be calling the doctor. Okay, would be our priority. If you have a prolonged deceleration, one that goes down and it doesn't come right back up, you immediately call the doctor. Okay, so it would be repeated decelerations, call the doctor. Prolonged deceleration, call the doctor. If you have a deceleration that would indicate cord compression, which would be variables or just a late deceleration, then you're going to intervene with turning or oxygen IV. Probably turning would be the best choice for an isolated one. Does that all make sense?
Yes.
So it would be knowing what the deceleration meant and what you would do for that type of deceleration is really what they're going to be wanting on an exam question. But the VIL chop helps you remember what that deceleration is caused from. Okay. I was trying to think if there was anything else that students really struggled with. Non-stress test. What do you remember about the non-stress test?
Kick counts.
Okay. Yeah. You do kick counts to see if the baby is moving appropriately. And if there's concern that maybe it's not, you would do a non-stress test. And we always recommend that they eat before they do a non-stress test, because it's not going to move well for you. And you want them to, you'll give them a little button and have them push the button when the baby moves. And you're watching to see that the baby's heart rate, when the baby moves and mom pushes the button, you're watching to see that the baby's heart rate goes up by 15 beats and stays up for 15. So up 15 seconds long. So that's how you count it. I mean, that's how you know that the baby's responding appropriately to the fetal movement. What's the difference in a non-stress test and a stress test? Okay, non-stress test, we're just making sure she's eating and we're monitoring the baby when there's no stress. Okay. It's just monitoring to see what the baby does with fetal movement. If we're doing a stress test on the baby, another name for this, a baby's stress test, is an oxytocin challenge test. And we would give her oxytocin to make her have some contractions. And with an oxytocin challenge test, we want 3 contractions in a 10-minute period. And we're monitoring just to make sure the baby has no decelerations during those contractions. She doesn't have to have accelerations, or the baby doesn't have to have accelerations during those contractions, but just to make sure there's no decelerations during the contractions. So if there would be a question about a stress test, an infant stress test, or a fetal stress test versus a non-stress test, there is a difference between the two. Okay, we're creating stress for the baby by causing contractions with an oxytocin challenge test. And with a non-stress test, there is no stress. We're just monitoring to see what the baby does when it moves. Okay. All right. Do you guys have any specific questions? I'm ready for a nap too, Ashley. You can make me yawn too. All right. Well, very best wishes on your exam. I know that most of you aren't my students, but you can always reach out to me if you have questions. All right.
Thank you.
You're welcome. You have a great week. Happy studying.
See you Monday.
All right. See ya. Bye.
Bye.